everybody knows.
Always the most fun announcement on Zoom.
No.
Well, while we're waiting for folks to trickle in, we'll go over some housekeeping. Thank you for attending today's training on social determinants of health, moving from information to action. I'm Courtney Jeffers, a member of the Maine Public Health Association and also research associate with the Center for Public Health, Center for Excellence in Public Health at the University of New England. So while we are waiting for folks to join, again, I'll go over some housekeeping. So this training is sponsored by the Health Equity Member Section of the Maine Public Health Association. Also, we sent out a pre-evaluation. We hope you had the chance to take it prior to today's session. If you didn't get to take it, I believe Heather sent it to you while you were in the waiting room, and we can put the link in the chat as well. And we ask that you take it while we go through the welcome. Again, if you took it prior to the training, you don't need to take it again. So closed captions are enabled. If you have trouble accessing them, please do let us know in the chat so that we can troubleshoot up front. And as we heard, a lovely Zoom announcement, we are recording this training. And as in the past, a recording will be provided to everybody who's registered. So we ask, again, as usual, that you stay muted for the duration of today's training. Please don't be offended if somebody mutes you because something's going on, but please try to stay muted yourself. And then after the presentation, we'll have some time for Q&A, so please enter any questions you have for Ian in the chat box, and we'll do our best to get to as many of them as possible. So again, welcome everyone. Thanks for being here. In the interest of time, we will get started. And as noted earlier in Heather's email, since we had a last minute agenda change, we may end a little bit early. So our first, well, and only today presenter and educator is Ian Yaffe, the director of the Maine Department of Health and Human Services Office of Population Health Equity. There he oversees Maine's initiative to address COVID-19 related health disparities, particularly among people of color and people living in rural communities in Maine. And prior to this role, he spent nearly 12 years as the executive director of Mano y Mano. Mr. Yaffe also proudly serves in the U.S. Coast Guard and is a trustee for Maine Health Access Foundation. Welcome, Ian. I will turn it over to you.
Awesome. Thanks so much for having me. Looking forward to the conversation today, and it's nice to see many familiar folks in the room and folks who have been working on these issues at the state level, here at the Public Health Department at Maine CDC, as well as in organizations across the state for a lot longer than me. So it is an honor and privilege to be with so many experts in the room. And I'm looking forward to sharing some of where we're heading in the Office of Population Health Equity, what we've learned from COVID-19 related health disparities, and how that helps paint the future for reducing health inequities more broadly across Maine, including with social determinants of health. So I'm going to share some slides. I have a presentation that I'll go through. Please interrupt me and ask questions, or raise your hand, put something in the chat. As much as possible, would love for this to be more of a conversation than a here's what I have to say and then like wait until the end type of thing. So please do that. And let me just get the slides up. And I think I've got that, and move things around. Great. So thanks for the introduction. Before I get too deep into talking about health equity and social determinants of health and COVID disparities, I wanted to start with a quick snapshot of where we are at this particular moment in time in Maine with demographics. And so one of the key focuses of the Office of Population Health Equity will be working with Black, Indigenous, and people of color as communities that experience health disparities and other disparities across the board. So centering race is a huge part of the work that we're doing. And in centering that conversation, I want to help to share with folks here, roughly 10% of people in Maine identify as being Black, Indigenous, or people of color. And while that is a small percentage, and we talk about Maine as being one of the whitest states in the country, that's also a lot of people. It's 125,000 people when we're talking about these issues. And so when we talk about health disparities that affect people of color in Maine and communities of color, I want to highlight that that is like talking about something that affects larger than many of our counties. And so this isn't something that affects a couple hundred or even a couple thousand people. Maine is also a very rural state, and so that presents some unique challenges. We're the most rural state in the United States in terms of the percentage of people that live in rural communities, which was surprising to me. And I think mostly based on the idea that we don't have a huge like metropolitan area. We have some areas that are bigger, but we don't have a huge metropolitan area that has a majority of the state's population. And then also people of color are all across Maine. So when we talk about rural and we talk about communities of color, those are not like separate things. And I just want to point those things out before I get into some more information about COVID-19 related health disparities and what that means for our plans moving forward. And so first I'll start with some trends and what things have looked like during the pandemic. This is probably a trend that folks here have seen before, where we look at Maine as being a place that didn't have a whole lot of COVID going on in the early days of the pandemic, saw some surges in the winter of 2020 and 21, and then a sustained surge throughout the fall of 2021, leading to a pretty significant peak that we are now just exiting out of. And so you can see these data again, now looking at the red line as the national trend in cases per 100,000, compared to Maine as the blue line in the, and then separating out Maine's numbers by rural and small metropolitan areas. And so you can also look now and you sort of see this trend in the pandemic where initially we were really talking about something that was predominantly affecting people in the metropolitan areas in Maine compared to rural. And then that flipped in the fall where we saw the majority of our cases and disproportionality in rural communities. Quickly then by a huge surge that we are now getting out of. This is just another way to look at that with cumulative information, showing that even though that, you know, largely at this point, the rates are very similar between rural and non-rural places in Maine. They've stayed fairly close together. But that's not the whole story. And so one of the most significant things that we have to do in all of our conversations about health is to disaggregate data, because what is true for the population as a whole may not be true, and usually is not true. It's almost always very predictably not true for communities that experience health disparities, especially for communities of color. And so these are the same types of information now, but disaggregated by race and ethnicity. And you can see during this period of time where Maine had very little, it was almost like the best in terms of a statewide case rate for the first year of the pandemic. It was like Maine was the top place to be if you wanted to live in a place that had very little cases per capita. That was extremely not true for communities of color in Maine, especially for Black and African American community members who saw the pandemic hit very, very early here in a very significant way that was not felt by the rest of Maine. And so these are the same data now looking at cumulative information, where you can see for Black and African American community members in Maine, for example, COVID was at a, about a 5% of the communities had COVID by the time we got to June of 2020, compared to for white community members, it took almost until September of 2021 to reach the same level of infection. And we saw that disparity continued. We never recovered from it, despite periods of time where COVID was not affecting communities of color as dramatically. That disparity stays very consistent the entire time, and it grows. And so at this point and this is still looking a little bit before Omicron has fully affected these data. But at this point, nearly 25% of Black and African American community members in Maine have experienced COVID, compared to about 10% of white community members. And that's a very alarming disparity that is also very predictable and follows a similar trend of other health disparities. And so I'm going to kind of go through the next slides fairly quickly, because I think there's not really a deeper meaning to it with COVID. Other than that, these disparities are still extremely prevalent and continue to affect us even as we move into different phases of the pandemic. So this is hospitalization information and death information, disaggregated and cumulative. And so we have seen now that white community members, for example, have the most disproportionality within the death rate, but that's not true of hospitalization and cases. We've also seen that we can make a pretty meaningful difference in our public health response by partnering directly with communities to plan interventions. And so one of those has been in the COVID-19 vaccination rates, where we have seen very clearly, after we exited some of the age-based eligibility tiers, that disproportionately meant that people of color didn't have access to the vaccine because of ages, that the rate of vaccination for people of color in Maine exceeded the rate of vaccinations for white people basically as soon as April of 2021. And that remained true with our boosters and additional doses of the vaccine, where we have not seen a disparity in those since those became available. And so what does all of this tell us? We know that COVID has affected all of us, but it hasn't affected us equal. And we also know that social and structural drivers of health inequities were made worse during COVID-19. So we had a lot of things that weren't working well when we entered the pandemic, and then they got worse for some communities, not for all communities. Some communities that's not true for. And we know that these disparities are related to increased exposure for longstanding and current inequities that go way beyond health, that connect to employment, in housing, income, and a whole bunch of other factors that lead to inequities in our health system and governmental institutions. But we also know that we don't have to accept those inequities as something that is going to exist forever. They are the result of daily choices that we make and daily priorities and resource allocations that we have. So what is Maine doing at this moment to respond to these inequities? We have been working internally and externally to reduce these inequities by partnering directly with over 48 community partners, representing communities of color, rural regions, immigrants and refugees, faith-based organizations, LGBTQ communities, people with disabilities, and more. And we've awarded over $14 million to provide education outreach, isolation and quarantine supports, equitable vaccine activities, and behavioral health and resiliency response. We've also launched a department-wide strategic plan to address diversity, equity, and inclusion, and there'll be a link to that at the end here. And we've reestablished the Office of Population Health Equity at Maine CDC, the office which I'll be leading, and we'll be growing a team this year to work with you all on. We've heard from our community partners that there are several recommendations of where we go from here. And that includes leveraging prior community assessments and recommendations, such as the Social Determinants of Maine report from 2019 and the Equitable Health Equity Data report from 2016. We know that we need to communicate in culturally responsive ways, provide more flexible funding, prioritize knowledge transfer with trusted community partners, invest in the capacity of community-based organization, and improve our data collection and publication of these data for vulnerable communities. And so now I'm going to talk about moving beyond COVID-19 disparities, which is what I'm guessing everybody is here today to hear about, as to how we are going to advance health equity across Maine. And so the US CDC defines health equity as when everybody has the opportunity to be as healthy as possible. At this point, that's a fairly non-controversial goal. At least for the past couple of decades, we have generally agreed as a public health infrastructure and systems and governments that we want everybody to have the opportunity to be as healthy as possible. I want to highlight that that agreement is in fact relatively new historically. And over the history of Maine and the United States, that is actually not a goal that the government has agreed on, and specifically decided that some communities were not worthy of being able to reach that goal. And so we end up with generational effects of those decisions that I just want to highlight. This is a relatively new thing in that generational arc of time that we even agree that that goal is something we should be reaching. And how we get there is going to be through programs. So successful health equity strategies, which I'll talk through, measurement, and in particular, using our measurement instead of waiting for data to be the source of we need to do something because there's a disparity, realizing that disparities are incredibly predictable and based on a variety of factors, and that our measurements need to be transformed into proving how we are having success at reducing those disparities instead of being the reason why we take action. And finally, and beyond the capacity of what one office can do, we're talking about policy. We're talking about laws, regulations, and rules that lead to the improvement of population health. All of this depends on having infrastructure, both at the state level and the federal level. So government infrastructure to specifically support health equity, as well as at the community level, and especially at the community level, that there has to be infrastructure to carry out all of these different activities. US CDC is transforming the way it approaches public health research, surveillance, and implementation efforts to shift from simply listing the markers of health inequities, which is what you have probably seen before, is like we know what they are, to identifying and addressing the drivers of these disparities. And for the national framework, that means CORE, so cultivating comprehensive health equity science. So really looking at this in the research, data, surveillance, and intervention strategies that we have, which is probably familiar to folks, but it will have, will take years to see the effects of that approach. Optimizing our interventions and basing them on social determinants of health. So addressing environment, place-based, occupational, policy, and systemic factors that impact health outcomes. Reinforcing and expanding partnerships. And so really looking at this as being something that depends on relationships at multiple levels across multiple sectors, not just traditional health organizations including traditional health organizations, but going well beyond to include things that we don't necessarily think of traditionally as public health. And lastly, expanding that infrastructure capacity and workforce engagement so that the team here and beyond and in all of our organizations is able to create a more inclusive climate, policy, and practices that will lead to deeper public health impact. These align very similarly with some of the goals from the Presidential COVID-19 Health Equity Task Force, which center some outcomes around community expertise and effective communication, ensuring that health equity is everywhere. It's not just the Office of Population Health Equity, but it's across all of our organizations and institutions, that we have better data and that everybody has access to high quality healthcare. And so moving more into social determinants of health, we know that everything that I'm talking about today, nothing is driven purely by public health policy or infrastructure. And social determinants of health can generally be grouped into 5 domains that all combine to affect an individual person or a community's health outcomes. And they include economic stability, education access and quality, healthcare access and quality, neighborhood and environment, and social and community context. And so if you really want to improve health outcomes, we have to look at those social determinants of health as the primary drivers of health inequities. And so some examples of the way that those health inequities are driven by social determinants of health include social conditions, a person's group being treated differently because of their race, class, sex, sexual orientation, immigration status, or other social factors that are exacerbated by economic conditions, which relate to unequal access to education and employment opportunities, and then also contribute to environmental conditions. So where you live, access to healthy food, opportunities for physical activity, exposure to violence, exposure to environmental harms, and social supports. All of those things are inextricably linked, and there isn't any way to move the needle on health disparities without a holistic and comprehensive approach. And we also know that we have to move them in a way that honors the way that intersectionality affects many of these social determinants of health. And so, for example, that's why we center race in some of these conversations, because despite progress that we've made on addressing poverty or improving health access or improving educational access, we still see race as a fundamental driver of inequity. And without centering it, we know that we can't affect the other inequities that connect. And we need to honor the way that those intersections combine with somebody's experience in our healthcare systems and in our public health infrastructure. So I'm going to get a little bit more specific now, and then looking forward to hearing some questions and talking about what we are doing with a series of initiatives designed to complement our COVID-19 response efforts and target the root causes of COVID-19 disparities, which are predictably the root causes of all health disparities. And so we have an opportunity here with US CDC funding and a $32 million set of initiatives across the Department of Health and Human Services to advance health equity by expanding capacity and services to address disparities, especially among communities of color and people living in rural communities. And we also know that those things are sometimes separate. So sometimes we'll be working very specifically on racial and ethnic disparities. Other times we'll be working very specifically on rural disparities, but many times projects will affect both sets of disparities. And So of that $32 million, we have three overarching priority areas. The first is data and reporting, where we'll be conducting a series of projects that lead to improvements in our reporting and data collection systems across DHHS to reduce the gaps that we have in our data, especially the gaps that are known on one side of the department, such as main care, and then on another side of the department, we don't collect the information. But as a department, we have it somewhere. So how can we connect those gaps while protecting personal health information? Lastly, we know that that's not enough. We have to improve our state data collection systems, but we also need to invest more directly in community-driven needs assessments, because the communities that experience health disparities already know what those disparities are, and they already have the solutions. And so we'll be specifically investing in opportunities for community organizations and communities to conduct their own needs assessments that will then complement our existing state processes and hopefully inform future state needs assessments, especially the shared health needs assessment. The bulk of our initiatives, though, focus on building state and community infrastructure and then mobilizing our partners to reduce health disparities. And this will include improvements to our engagement and communications tools so that we can more effectively reach community members regardless of the language that they speak. We will be increasing department capacity, especially through the reestablishment of this office and the development of a health equity advisory council to bring community partners, health providers, and advocates together to come up with our strategy for the future. And then some targeted investments in rural health infrastructure, including a community paramedicine and systems of coordinating care project, rural health workforce development, and another set of initiatives led by our Office of Rural Health and Primary Care. On the partner mobilization side, we'll be investing heavily in community-based organizations addressing health equity to ensure that they have infrastructure support to be able to function and come to the table in all of these different efforts and be able to function as organizations and communities. We will expand the deployment of community health workers in our COVID response efforts, both through this program and through a bunch of different initiatives across the department, looking at expanding the use of community health workers. And then finally, a series of pilot programs looking at expanding access in rural communities, including rural school-based health clinics and health centers, our district and local public planning processes and emergency preparedness activities, and a couple other pilot projects like that. All of this is guided by work that folks here have been involved in for many years, and that includes the department's strategic plan to address diversity, equity, and inclusion, the main shared community health needs assessment, where there's a whole section on social determinants of health now, and health equity and social determinants of health are a major piece of the strategy going forward. We have our social determinants of health in Maine report from 2019, where you can go much more in depth to see how things play out, not only by race or ethnicity, but by other factors like poverty as well. And then we have a health equity data report from this office. Actually, before it didn't exist, one of the last things that happened was that we laid the foundation for health equity data collection moving forward. So we're excited to take that back up, figure out what has happened and what hasn't, and ensure that we continue to work forward towards that. There are also national resources here. So US CDC has been really building its capacity on understanding the intersections of racism and health, on inclusive communication, on social determinants of health, and on how to reduce health disparities. And I also want to highlight a report from 1985, which will have very similar conclusions that we just discussed. And so highlighting that a lot of this work the foundation has been there for a long time. And what's changing now with COVID in particular is that resources are now being allocated towards communities and towards social determinants of health in a way that has never been true at the federal level in particular. And so that will have ripple effects here in Maine in 2022 and then in years to come. So I'm looking forward to hearing questions and having more of a conversation with you. And then also just want to highlight that this is all the beginning of the work and the reestablishment and prioritization of social determinants of health and health equity across public health as a broad system that goes way beyond state government, way beyond our healthcare systems, to really look at all of the competing factors that influence folks' ability to have healthy outcomes. Thank you for having me today and looking forward to talking more.
Thanks, Ian. Lots of great information. It's good to see some action with to back up some of the data and the understanding. So I appreciate the slides. Do we have any questions in the chat, Heather?
Yes. So one easy question. Are you able and willing to share your presentation with us?
Yes, and actually I'm trying to put this onto the Office of Population Health Equity's webpage and start to build out all of these resources so that they're not just living in your email, but there's a place that you can go back to them. So I'll work on finalizing that and then getting a link that you can include in the notes or when you send out the recording so that you can have these and share them easily and link back to them.
Great, thank you very much. The next question is around obesity. And Lori is wondering if there's an impact from obesity on the rates of COVID-19 with respect to racial inequities, knowing that communities of color often experience higher rates of obesity.
I would be somewhat speculating here, so I don't have an exact answer to the question. I know that obesity is one of the risk factors. So like what you described is somewhat the answer, that yes, obesity is recognized as a risk factor for more serious COVID effects. And we know that some communities have higher prevalence of obesity. So it's one of many factors that can lead to more severe effects of COVID in different communities. But I think it's just one of many. And that's where, I think that's really where this conversation about social determinants of health goes, is that we spend a lot of time focusing on the individual disease conditions, and we still are going to focus on individual disease conditions. Like, don't get me wrong, that doesn't go away here. But I think what we don't focus enough on, that's like a downstream effect. We don't focus upstream enough on all of the conditions that lead to a prevalence of obesity, including education, income, wealth, environment, housing, where people live, our food policy in general. There's a whole bunch of other factors. And I think that's where we're trying to strike a little bit more of a balance as a public health system moving forward, is to continue to have downstream disease interventions, because we can't ignore immediate health challenges that folks face, but to ensure that that is not solely the only approach that we have, and that there are also upstream ways of looking at how do we prevent those health conditions from happening in the first place, and how do we target our prevention in strategies in a way that centers the communities that experience the hardest, that are hit the hardest by health disparities. Because we know that we can move the needle on obesity rates, in this case, as a population. We can move the needle on that as a state and see disparities get worse at the same time. And so without focusing on the communities that are hardest hit, we risk doing exactly that, making progress as a whole while we actually worsen the gap in some communities.
Thank you, Ian. The next question is from Wendy, and she's wondering if your office is considering investing in a platform that would improve care coordination around social needs, such as Unite Us or Good Grid, and that perhaps that's an opportunity to connect healthcare systems, CBOs, main care, DHHS, et cetera.
Yeah, I know there are a couple of different platforms out there, so I have seen them before, and I can follow up with that. I think I think that that's definitely part of the strategy for health equity infrastructure building, is to ensure that we have ways to more effectively include partners in our health systems and in health response. But I don't have a specific answer as to like which initiative is that going to happen with. I think the first thing that we'll be doing is working to build the capacity of those community partners to be able to even be linked to some of those systems in the first place, and then look at ways that we can do that. So I know that that's sort of not a very clear answer, but it's the best that I have right now.
Thank you. Another one we have is a bit around infrastructure and workforce, and about using community health workers and how that's a great action step, but that there seems to be a shortage of these professionals despite their recognized importance role. Will your office be doing anything to support or fund CHW training and recruiting?
Yeah, that is, I think that one has a more clear answer. We'll have several different initiatives happening this spring and summer to, one, just increase the funding that's going to community health workers so that you can hire them, and community health workers can have a living wage and benefits and things like that. Part of those initiatives includes deepening our own capacity to train community health workers across the state. And so there are a couple of different initiatives happening with that. And then there are a couple of other new federal grant opportunities for this that haven't even hit yet, that I think there are folks kind of in the application process of looking at that. And so basically the short answer is yes, and it's only going to expand from here. And there are some other efforts on the other hand so we're looking at a pretty large infusion of federal grant dollars to support training and deployment of community health workers, which is all related to COVID, which means that it goes away in a couple of years. And so the other piece of the strategy is that we're looking at ways to ensure that we can tap into other resources to help support community health workers and recognize the valuable role that they play in our health system beyond COVID grant dollars. But that COVID grant dollars means we're kind of talking about like beyond 3 years from now.
Thank you. And this next question builds on that a little bit in terms of planning for continuity of effort and sustainability and leadership if there's turnover beyond the state and federal administrations, and just what does this work look like moving forward?
I would love to have an answer to that. I think that's just like super complicated and somewhat outside of our control. Without punting it, like I think that's one of the challenges in government, is that there is so much turnover, not only in our career public service folks like myself, like I'm not a politically appointed position, but also in our politically appointed positions, that's just something we have to adapt to. One of the strategies that we have to ensure that we have a longer term lens is, I think, pointing towards having more clear strategic plans and priorities, but it certainly doesn't go away. And the other way that I think we do that is by more effectively partnering with each other, so that the state isn't the only, or the government in general isn't the only driver in some of these decisions, which means that, you know, there's more volatility because there's one place deciding it. But when we do some of these things together, we reduce that volatility because we're bringing more voices to the table, and more consistency And so that's kind of the way that we're going to approach some of this work in the Office of Population Health Equity, is to really center the experiences of communities that have lived experience in health disparities, and ensuring that our efforts are informed and reflective of those communities, and not so it's not really about like what my vision is, and then if I change, now it's like, what's the new vision? It's really like more, how do we bring communities into that visioning process so that it's less dependent on individual staff or leaders to guide the path forward? Because we know it's not going to be effective. Like if I come up with a strategy for health equity for the whole state of Maine, that would be ridiculous. So my role is really more of a facilitator in that process, to bring voices to the table and recognize that the more that people are included in that process, the stronger that our plan is going to be, and the stronger that our outcomes are going to be, because they're reflective of people who are proximate to those challenges.
Thank you. That's great. I appreciate the comprehensiveness of that answer, because you got to a few more questions that were in the chat. This one is switching gears and a bit more specific. So I don't know what your office or you are doing with this, but how can health equity efforts address the public health harms of incarceration in Maine, specifically thinking about the health impacts of parental incarceration on children, as well as gaps in care and COVID exposure that people face when incarcerated?
I mean, I would say that those are very closely related to social determinants of health. And so without necessarily having a direct thread, addressing social determinants of health means that you have to address those effects. We can't look at public health and say that somebody's experience, it's really all about centering folks' experience and where they are. And so some of those experiences we have traditionally ignored and said like, well, that's not part of public health, or that's not part of health, like you should just be healthy, because whatever, like we have healthcare, so you should be healthy is kind of our approach. And so, and then we know there's people who don't have healthcare, and that's like a whole, like we need to improve access to even get to that point. But I think really focusing on population health and health equity means that all of the experiences that people have that contribute to where they are in the world today are on the table and are valid for conversations. And so without getting into like, there's these two different strategies. One is like recognizing effects of those experiences as one strand, and the other is actually looking at ways, social determinants of health also affect incarceration. And so, focusing on social determinants of health as an upstream priority means that there will be downstream effects well beyond the public health system.
Great, thank you. We don't have any more questions in the chat, but to wrap up, I have a question for you. And
Sure.
then we'll close out. Do you have a specific timeline for or benchmarks that you're looking at? How are you thinking about measuring success and measuring progress?
Yeah, that's a great question. I think in some ways, there's no simple answer. Like the shared community health needs assessment has a ton of different benchmarks that get updated over time that are really useful here. Like if we can drive those, that would be amazing. And the social determinants of health report also has a series of really useful benchmarks. So I don't think we're really in a case of having too little data to determine what the effects are. I think the challenge is that those are really hard things to do. And so addressing wealth and income, racism and discrimination, those are the benchmarks for success. They're pretty easy to measure at this point because they're so prevalent, but they're really hard to untangle. And so I think the plan that we have is essentially, and so for me to say what those are now without having done the community engagement to get to that answer would sort of contradict the whole part about bringing people in. And so where we're heading with that is kind of looking at parallel to the shared health needs assessment process, building this health equity advisory council and a team doing engagement focus groups and things like that to get at what priorities are for the next 5 years, because there's a lot of different drivers that we could just arbitrarily pick. But we want to hear directly from the communities that are most impacted by health disparities. What are the priorities for the next short term, and how do those connect to the long term? But I think the priorities are still pretty clear. It's just that they're hard to move. And so by the end of this year, I think we'll have a better sense of that and more of a strategic plan or framework to guide us with, knowing that our ability to drive all of those things is somewhat limited, but our ability to amplify those priorities and to see ripple effects in our partner organizations, in our health system, and in our public policy arena is kind of the promise that we have in bringing these coalitions together.
Yeah, thank you. And thank you everybody for attending this training. Ian mentioned the word amplify. And so this training is the first in a series of offerings that will occur over the course of the next year, and we'll focus on these community programs and kind of amplifying the work that they're doing to reduce health inequities in their communities. So in each session, we'll hear from a community-based organization about the successes of something they've implemented in their community. We hope to hear from somebody with lived experience of working with that program. And then we want to hear about their existing needs as well. And then at the end of each of those sessions, there will be designated time for us to break out into Zoom rooms, process what we've learned in order to continue to identify steps to action and how we can become allies in our community. So we want to continue to support our community-based organizations and get the word out there that they are doing some great things, and also give us time to connect and maybe brainstorm about how these things can work in our own communities and how we can adapt to them. So thanks again for participating in this training. Another word that Ian used is unraveling and intersectionality, and how all of these things affect people and affect them differently. You can't say that someone has experienced being unhoused and then also food insecurity, and so they're affected with this template kind of way. We know there's so much unraveling to be done. So be on the lookout for one more educational foundational training before we start with the CBOs. It will be in April, and it will focus on this intersectionality and social determinants of health, how those present unique social risks and social needs in our main communities. So thank you again, Ian, for your time, for your expertise. Thanks everybody for being here. We hope to see you throughout the year. Take care.
Thanks, everybody.
Great. Thanks for having me. Have a good rest of the day.
Thanks, everyone.